I'm Jill, and I'm part of the Bonterra team. I've been around Bonterra for about 20 years, both as a customer and now as an employee. And so excited to have you all talk with my friends at Health Roads and with Suzanne and Elaine, and to introduce them here shortly. So this is all for you, organizations that are interested in what it looks like to bill for services. And so we're excited to get started here. And so Elaine, if you could go ahead and introduce yourself.
Hello, everyone. My name is Elaine Lapson, she, hers. I'm a deputy director over at Little Manila Rising. And I've been with the organization for over 8 years. I oversee our health programs ranging from asthma mitigation, mental health, as well as community education and health education.
Amazing. Goldie?
Hi, everyone. I'm Goldie Mandela, Director of Product and Services Operations at Health Roads. I oversee implementations, post-implementation support, and I help to prioritize your backlog of product requests.
And Suzanne?
Hello, everyone. I'm Suzanne Warner. I am the founder and principal of SC Warner Consulting. I work with a lot of community organizations and government jurisdictions on leveraging Medicaid. And in a former life, I did a lot of housing and homelessness work for government. Great to be here with you all.
I'm so excited to partner with you all. And this webinar today is for every one of you that joined to learn about billing and services that are billable within the Medicaid and private insurance realm. And so this is for you, whether you're a small CBO just getting started and are curious about all of this, or you're a community hub who's working across multiple organizations within your network, or even a health system looking to stand up a partnership with CBOs or nonprofits around rural health transformation, which is coming down the pipe here. If you've ever wondered whether your organization qualifies for enhanced care management or community supports or ILOS, if you're outside California, the answer for most of you is yes. And the good thing to know is you're not alone. And the other good thing to know is these ladies on the call with me are experts in answering and helping you figure that out. And so if you're already using Apricot today, you have a significant head start because you are already collecting a lot of data that will help you to submit claims and make those services billable that you're already delivering in most cases around intake and assessment and intervention. So the problem that we've uncovered here is that here's the uncomfortable truth, right? The Medicaid system funds social care interventions at scale, and we're talking like 94 billion annually in Medicaid spending tied to social determinants of health. Housing, nutrition, care coordination, things you're already doing. And yet fewer than 5% of organizations are actively billing for those services today. I know when I worked in a nonprofit 20 years ago, we went down the try to bill for Medicaid route for therapy services, and we never accomplished it. It was too complicated. But today the story is different, and I'm excited that you have these wealth of resources here to help you get going. And what we know now is that the gap is not eligibility for services. The gap is infrastructure, right? And having the people on your side to help you get it set up and going. Most organizations don't have electronic data interfaces or EDIs capability. They don't have payer contracts. They don't have the revenue cycle management layer of technology solution to be able to submit the claims in an easy way. And that's exactly the problem that we're here to solve with Health Roads and Suzanne's help. So the opportunity is real right now, right? There is the opportunity to bill for these services you're already billing for: enhanced care management, community supports, value-based outcome contracts. These are all live funding streams. An example is California. We know California alone has committed more than 12 billion to what's called CalAIM through 2027, and new 5-year waiver is waiting on CMS approval. And rural health transformation is live. It's here. There's federal dollars that have been appropriated for that, and states are putting in the proposals for how they're going to use that money with CBOs and qualified health providers nationwide. So this isn't a future state. CBOs are billing today, The question is whether your organization is positioned to be one of them. And that's where I want to bring in Goldie, because she's going to show you exactly how the solution is structured. So let's go ahead to the next slide around solution.
Yeah,
so go ahead.
Thank you, Jill. Just wanted to share with all of you how everything ties together. So you've got your Apricot case management, member engagement, documentation already happening. Once there is a contract with a managed care plan or a health plan, then we bring in the interoperability to pull the data out of Apricot, to transform it, and then also to deliver it to the health plan and receive back the information, the adjudication, so that you know the status of your claim. But on top of the product and the interface that we bring to you, it's not just a billing system. We actually bring expertise to you. So the SocialRCM system was born out of social care and billing to Medicaid. There was a need, and we sought out to fill that need. And now that's exactly what we're doing for CBOs like yours, because if you have not entered into the arena of medical billing before, there's a lot to know about it. So we want to make sure that we guide you through the entire process. We make sure that you're capturing the right data so that everything is compliant to go out on a claim to that health plan, and then, of course, translate into revenue on the other side. So that's what we're here to do for you. Okay, so this slide breaks it down a little bit further. We do the 837 EDI professional and institutional type claim generation. If you don't know what those things mean, that's okay, because we do. We also pull back in the information on your 835 electronic remittances. That is what tells you if you were paid or denied, or what else is happening with your claim. We also can provide eligibility verification for you. So if you want to go through a process of checking eligibility before services are provided or as part of the claim process, we can do that type of communication to your health plan as well. And then there's even some assistance with the payer contract management. So if you're brand new to this and you haven't even started yet, you just need some guidance in how to get started, how to put together an application packet, and ultimately get to the point where you're billing and being reimbursed. That is something that Health Roads can do as well. And lastly, our denial management and appeals is where we offer dedicated post-implementation support so that you know exactly why or how much you're getting in terms of your payments. And if you are not receiving payments for any reason, we have somebody who helps dig into the root cause of what's happening, whether it's a denial or whether it is rejection. There's a variety of different things that can happen. In some cases, even underpayments can happen. So we're looking at your expected reimbursement versus how much you actually get. This support person will then help to analyze what's going on in the data being collected. Is there anything we need to update or change in your workflow? If everything looks good there, is there anything that we need to change in our validation rules that would help to prevent this type of thing going forward or resolve these particular issues? And if both of those are in good shape, then this support person also helps to advocate on your behalf with the health plans. Because what's happening when you start billing is that you enter the machinery with these health plans of medical billing. And there can be reasons that claims are denied that have nothing to do with whether or not you performed the service or whether you documented accurately, or even if all the systems are working appropriately. It is possible sometimes to still get a denial, and we have to understand that and be able to go after those with that evidence. So that's what we help with as well.
I think that's key with how Health Roads helps, is that not only have we built the systems and we've connected, Apricot with SocialRCM to be able to process those payments, but they have team members on your side that's going to help them figure out why the denials are happening. A lot of times when we talk to our clients or prospective clients now that might be using other platforms, they'll tell us things like, we have $26,000 in claims sitting and we haven't been able to figure out how to push them through. And I've seen where Health Roads have come in and been able to even get those back claims paid. And I think that's really important, is having that partner on your side that can help you understand, why is this not working the way it's intended to work? And a lot of times it's something simple or something on the insurance side that, you know, they need to have that expertise on their side to help them push that through. I want to bring in Elaine next. Elaine has implemented these solutions, so I'd just to love to have her come and talk, and so you have proof that this works and other people are using it. And Elaine is a great success story with her organization.
Thank you, Jill. I'm going to bring in some context into our work and why we got into where we're at today. So prior to starting this work, our organization is centered around historic preservation. With Little Manila Rising, it was founded in 2000 to save what was left of our historic site in South Stockton. And this was home to the largest population of Filipinos outside of the Philippines until the freeway construction dismantled it. And so we believe preservation is an act of equity. And we moved into education equity and empowering our young people about their histories. But what really shifted our work into health is losing our co-founder, Dr. Dama Balin, to an asthma attack in 2018. Her loss shifted our focus, which got us to really build out our health programs, responding with asthma mitigation, community education to address conditions driving poor air quality outcomes. We also dived into mental health services as well, which eventually we built a community health worker model and care navigation, which are the connective tissues of our whole person care. A lot of these services and work are services CalAIM and Medicaid now funds, our community supports through Department of Healthcare Services, and we have been delivering them largely without reimbursement for years. And so when we entered CalAIM, we didn't come with a billing department. We came with programs and community trust. We applied for grants and applied for technical assistance through Department of Healthcare Services, through the TA Marketplace. And that's how we got connected to Health Roads. We leaned a lot on them to help really build our infrastructure for policies and procedures, really bringing up the work with SocialRCM and building up that infrastructure. And they also helped us get connected with a qualified health organization, information organization at QHIO. We also were awarded a grant through the Department of through the data exchange framework, which did require us to bidirectionally work with a qualified HIE, and that was part of the compliance mandate. It wasn't something that we did not know how to do ahead of time. And so all while doing this, we had to start from the ground up. And we were really open to learning a lot of these processes, which we, when we entered into like this Medi-Cal realm, we had to also learn about the language and everything, especially from an organization that was used to just language in the way that we spoke to our community. And so now there is a through line through all this like infrastructure and navigating. It did take some time. We are now onboarded with SocialRCM, Apricot, and working with a QHIO. And are open to the opportunity to seeing how things progress in real time. I say that because when we started working with a QHIO, we were limited with our portal access. We only got to see some patient data, not the real-time data that we needed in order for us to do the services that we know we can do from the ground. And so I think being able to be really being able to understand that there is a lot of work behind building up the infrastructure. But again, when we are able to see these like streamlined processes that Apricot and Health Roads have created, it does allow us to go directly with what we do best, and that is delivering our services and reaching our community, and being able to know that our services are doing what we can at the community level.
It's an amazing story. I love, the expansion of services based off of that tragedy and how you're helping others now as a result. And all of, getting all this set up, like we could tell through what you said, it's not easy, but you had help. And so next I want to introduce Suzanne, and you work with nonprofits and organizations that are at the very beginning of this journey, and they may not be as far along as Elaine's team is now. What are you seeing on the ground when it comes to billing readiness?
Yeah, thanks, Jill. I work with a range of community organizations, both quite small to quite large and spanning multiple counties. And the one thing that they all have in common is that Medicaid regulations and billing is a completely new landscape for them, right? And so I'm going to zoom out and give you an example that will kind of bring us to a higher level, but shed some light on the importance of having that data infrastructure in place. In one large community in California that I was working with, they were preparing to implement a new Medicaid waiver that would fund housing services for eligible managed care members that were experiencing homelessness. However, the majority, if not all, of those housing service providers were unfamiliar with Medicaid billing and regulations. And in a large community like this one with several providers, it didn't make sense for all of them to build duplicative infrastructure especially with the small and medium-sized agencies, with little time or resources to support that kind of lift. And so in this community, the county, who already had contracts for services with those same providers, saw that they could play a valuable role in positioning themselves as an intermediary or a community hub or a lead entity. You may have heard any one of those three terms used interchangeably, but they all reference a model whereby that lead takes on responsibility for meeting those Medicaid regulations, quality assurance programming, reporting and data sharing, and the billing and claiming, and executing the contractual relationships with the managed care organizations. In this particular community, that lead entity also was able to support very specific community goals, which included ensuring access to Medicaid services for everyone who is eligible by building this hub, this large provider network with several providers in different locations, leveraging early data sharing processes that were already in place between the county and managed care and the service providers, implementing more standard data exchange protocols across the network, and essentially removing the operational barriers for their housing providers so that they could participate in this Medicaid waiver program. The community hub began with a manual billing process, so think Excel spreadsheets, and no EDI capability, which put their services reimbursement for approximately 1,600 initial participants at risk. And they knew that they would be increasing those services quickly to serve over 3,000 members at a point in time, based on who's in their community and the capacity of their provider network. So it was imperative that they moved quickly away from the manual processes. So the solution is, what we're going to see more of on the next slide, but really highlights how data sources can be pulled together and combined to produce clean claims for managed care plans, and how that can be monitored for management of the revenue cycle to make a large model like this work. In this community example, that included pulling in data from their homeless management information system, or the HMIS, invoices from their housing providers, information from the managed care plans on authorization for services, and then all of that comes together and is converted into an EDI claim and encounters that are submitted to the managed care plans. The nice thing about this solution was that it kept associated costs down while not sacrificing compliance. And it demonstrated that not everything has to be built in-house for each participating agency. It was a nice way to really leverage that integrated data structure that could support an entire network. The outcome of this was that Medicaid waiver program was scaled from 4 to 20 community-based organizations participating in just under 2 years' time with this new billing system. And today they're still going strong. There's 24 community-based organizations that are participating, and now the program serves about 3,500 individuals daily with these Medicaid reimbursable services.
Wow, that's amazing scale. And they can, continue to accept new partners in that model as well pretty easily.
Exactly. Yeah. Now that the infrastructure is in place, they can really keep bringing in more people and keep serving more and more people.
Wow. And so the slide here, what we're seeing is that how all of that happened, all that connectivity between systems. And then I think the biggest benefit here too is the reduction of having to manually enter things in all of these systems, going from 3 places to enter data to 1 place that we enter data, and then it just flows where it needs to go. And that is a story that every frontline staff member would love to hear when they might need to input into multiple systems today.
Yeah, that's exactly right. I mean, I think, just like you said, Jill, the multiple systems where information lives without that data infrastructure to pull it all together, it can be administratively quite cumbersome to try and pull it together yourself manually. And we see a lot of CBOs really struggling with that. And it's all a new line of business, right? They've historically relied on cost-based reimbursement, grants, philanthropic funding. And so this baseline infrastructure isn't necessarily in place. And so without integrated systems like what is shown here that can really support the data and billing solutions, I see many community organizations opting to not seek reimbursement for services that they're already providing that are Medicaid eligible, or they're executing contracts with the managed care organizations that they then can't bill for. Or they're billing very minimally and only collecting a portion of the reimbursement that they're eligible to receive. For example, in one California community, there were a few providers that executed contracts with their managed care plans, but they didn't submit their first claim until 2 years later. So their contracts just sat there with that unrealized revenue. I also see CBOs that are trying to bill on their own without this integrated data in place, and finding that because they're only collecting a fraction of the revenue, because they don't have all of that information to come together to really manage that cycle, they sort of give up and declare that the Medicaid program isn't paying enough to cover their costs, when in fact the greater issue is that their costs aren't being covered because they're not able to leverage that full reimbursement by pulling this information together. I think ultimately with funding reductions that we see at local, state, and federal levels, we can't afford to leave crucial dollars on the table. And so ultimately building these bridges between social determinants and health data so that the eligibility, the encounters, the outcomes flow cleanly to managed care organizations is really going to help reduce denials, increase reimbursement, help agencies prove value. Goldie, from the Health Road side, what makes Apricot and QConnect uniquely powerful in this context compared to what CBOs are trying to put together on their own?
Yeah, so for starters, Health Roads is also a certified Apricot implementation consultant. So this partnership with Bonterra gives us that deep understanding of both the social service operations and then also those reimbursement requirements. So from that regard, we help organizations identify that information that needs to be captured, and then how it supports billing, how the documentation workflows support that successful reimbursement. But then to coincide with that is the QConnect interoperability, where now we're also connecting to the QHIOs, the HIEs, the HMIS, all the things that we have listed here, or even data hubs your database, as well as that connectivity to the health plans, where, we convert it into whatever type of data is necessary for each of these interfaces. So whether the health plan wants EDI, somebody else needs HL7, someone else has an API, all of those different forms of communicating data fall within the QConnect, sphere of ability. So it's a way to pull everything together, everything you're already documenting in Apricot. We leverage that information. We help you understand what minor changes need to be made. We get the information, build using QConnect, and then we also connect all of these other areas so that you're not rekeying that information, or to pull in the data back to Apricot as needed.
Yeah, and I think what's important is that between your account manager and the Health Roads team, we're going to help you figure out what all of that means. Like, if we've thrown so many acronyms at you, you're like, oh, I don't know what all those are. It's okay. We understand what they are, and we're going to help walk you through all that. And I think the next slide is what's really important, which helps people to see what's billable. What are billable services that we can start to look at for reimbursement? So wondered if Goldie, Suzanne, you guys could walk through some of the highlights of this slide.
Yeah, I can start here. So, as I mentioned, SocialRCM was purpose-built for social care, also born out of CalAIMS. So, some of these services that are listed here are very specific to California. However, we have since seen the expansion throughout multiple states in the nation. And many of these same exact type of services, although they may be called something a little different, are now being reimbursed by those state Medicaid plans. So what we look for are, what are the billable services in your area? And then, if you already have your managed care plan contract, that's excellent. Sometimes we even have suggestions for other services. Since you're already providing services in a certain realm, maybe there's a few others that you could have added to your contract. And then, who are the eligible organizations? This is really going to be anyone who is providing those social services and able to get reimbursement back through that Medicaid managed care plan or managed care organization. Other states might call it a CCO, MCO, MCP, lots of different acronyms there too. But really, it's anyone who's providing those additional social services that is looking to take advantage of the reimbursement from their state.
Keith, in the questions and answers, Keith was asking about community health worker billing. Anything you can expand on there?
Yeah, absolutely. There's definitely been an expansion in community health worker billing. This is, maybe you're serving a population that doesn't quite meet the eligibility criteria for enhanced care management. Or maybe you just don't have people who are doing as highly complex care coordination. So there's a huge need for, that level of care out there in the communities. So it's definitely an opportunity.
Awesome. All right, and the next thing we're going to go over is how do we get started with this? So on the next slide, Goldie, if you could walk through what that path looks like to get everything set up.
Absolutely. So you're looking at approximately 8 to 10 weeks total. We do start with the readiness assessment, where we come in and take a look at how you're documenting in your Apricot system currently, what your configurations are, and then we notate any gaps. So if there's some changes that need to be made, we know what those are up front. And then there's the payer contracting layer. Now, if you're already contracted, obviously this cuts some weeks out of your implementation. And the length of time it can take for payer contracting really varies. So this is just kind of an estimated average. But if you're not there yet, you have not submitted your application packet, one of the things we can help you with is to put together what you would need, how you want to position yourself, what policies and procedures you need to have in place in order to do these things. And then we can actually help you put those things together, not just inform you what you're missing, but actually help you have them in place. You'll note here in the notes a BAA execution. That's a business associate agreement that ties into HIPAA and high-tech compliance. And because you haven't necessarily billed services before that fall under medical and HIPAA compliance requirements, we also help you with that layer as well. Now, then we have the SocialRCM configuration. Again, one of the beauties is that we're already so familiar with Apricot that we can pull together the configurations based on your health plan contract, as well as just the state level program requirements, which are it's public information. And then we already know what data we can get out of that Apricot system to turn that into a claim. The QConnect integration is where we connect to obviously your health plan for the EDI. That's the 837 claim billing and the 835 remittance information that comes back from the health plan, as well as some of those other acronyms we mentioned earlier, your health information exchange or your qualified health information organization. We can set up that connectivity to all of those. And then we reach the point where the first claim is submitted, and you're still really in implementation at this point because we're monitoring very closely with you how that billing and adjudication process is going. And then once it is fully stabilized and everybody's confident that the data is being collected accurately, the configurations are set up accurately, then we would transition from implementation over to that dedicated support. So you get to continue working with us. We definitely don't just hand you a system and walk away. We really partner with these organizations to make sure that you're successful, and then your success is our success.
Awesome. What I appreciate is that you're really honest with the timeline here. It's going to take time to set up, especially if you don't have those payer contracts in place. But you guys will be there alongside and can start and stop as needed based on how the organization, where the organization is in the journey and what resources they can lend to the project. Just the way that we see when we're implementing Apricot from scratch, we can be as flexible with that configuration, and there will be probably need to be some configuration changes to your Apricot instance as well to match up and collect all the information needed, but that's all just configuration project. There's no code that needs to be delivered or anything like that to get Apricot to collect all the data you need to pass to the SocialRCM tool for billing. And so the health road support is really important, which the next slide outlines. And I want to underscore the audience, Health Roads has been great partners to all of our existing customers that have implemented their Apricots over the years. And now the SocialRCM product, we've seen huge success with the customers that we are partnering with on so far. And so Goldie, if you can just go a little bit more into the
Absolutely. So, of course, I get a little excited and get ahead of myself. So, we talked about the payer contracting expertise. We do bring resources to you to really help you navigate that world and give you the best chance of actually getting those payer contracts. Similarly, business associate agreements and subcontractor business associate agreement navigation. Because we operate as a HIPAA subcontractor, we handle the business associate agreements. We make sure that you have it in place. We get that executed with you. And then any downstream subcontractors, we take care of all of that as well. So that's just part of what we offer with our general package. The clearinghouse onboarding, we have partner relationships with major clearinghouses. And in some cases, we can just link directly with the health plan. This is true for some of the services that you bill directly to the state health plan instead of a managed care plan. So, whatever the connectivity needs to be, we're prepared to be that interoperability layer. And then with the EDI, this is, again, is the 837 claim files, the 835 remittance files. We provide robust testing before we even send out that first real claim. And then we talked about the post-implementation support that continues beyond that time as well. And then implementation acceleration. So we can compress a 6-month implementation into just a few weeks for Apricot customers because of that familiarity with the source system. So we already know that we can capture all of the data that's necessary for billing rather than having to really do robust discovery to see what we can capture and find workarounds if we can't capture it all, that type of thing. So it really helps to streamline the process for Apricot customers.
Awesome. And what I really want you all to hear is risk mitigation, right? They're taking all the risk out of this process and really ensuring that it's going to be cost effective and that the reimbursements are going to happen. So there's return on investment for all of this. So return on investment, risk mitigation, if you're taking this back to others on your team, that I think are the two highlights that you want to put throughout there, is that they're going to really help with both of those things. So next slide is, what do we do from here? And so we have a couple of steps that you can take to learn more. And while you're viewing these, we have a couple questions in the Q&A, but feel free to put some more in there while we are talking about next steps. First is that you can schedule a free discovery call with Health Roads and their team by just going to their website, health-roads.com/contact. And it'll take about 30 minutes to assess your billing readiness, identify your payer opportunities. Second, if you want to see SocialRCM, QConnect in action, they can do that. They can show you how the data starts in Apricot and how it flows into these tools. So they can demo a live instance of how that's working for you, so you can see that. And third, if you're in California, there's a CalAIM qualification guide that you can go out and Google search for. That gives real plain language walkthrough of what ECM is, what community support eligibility looks like. If you're outside California or you're interested in the Rural Health Transformation Program, Health Roads can also help you find documentation for that. So we put up a little poll if you'd like us to reach out to you instead. You can answer these questions or just tell us no thanks, you're set for now. And that'll help us to reach out to you directly if you'd like some reach out. All right, we do have some questions in the Q&A. Goldie or Suzanne, can you dig a little bit into more about what ECM means, enhanced care management? What is it? How can people bill for that?
Certainly. Enhanced care management here in California, where I'm based out of, it's a comprehensive Medicaid benefit designed for the highest need individuals, so highly complex clinical and non-clinical needs. And the idea behind enhanced care management, and I think there's sort of similar versions of this in other states as well, is that it connects members with a single dedicated lead care manager that stays with them, and they're tasked to coordinate their care across physical, behavioral, and social systems. There's several different populations of focus, as they're called in California. So people can qualify for enhanced care management based on their status being homeless. Individuals with high-risk chronic conditions qualify. There's a behavioral health population of focus. So individuals that are experiencing severe mental health or substance use disorders qualify. There's also a population of children and youth with complex needs, and pregnant individuals that are experiencing homelessness or substance use challenges here in California. And it's really kind of the the core case management model of following someone intensely and intensively rather, and making sure that all of these different systems of care that they need to access are coming together, and that the member isn't kind of stuck on their own trying to navigate several different systems to meet all of their needs.
Thank you, Julie, for that question. Any follow-ups, feel free to put them in the Q&A. Ruben asked, which version of Apricot do you need to make this work? So there's different versions of Apricot, Essentials, Core, and Enterprise. If you have Enterprise, you have our connectivity included, which is API or secure file transfer, real-time or batch transfers. We can integrate with the SocialRCM system or QConnect through both batch and API. So if you are on core version, you would need to add our license for integrations in addition to core, or upgrade to enterprise to be able to make the real-time connections. So you can talk to your account manager about getting that added onto your contract if you are currently on essentials or core version of our software. So you will need connectivity that comes with enterprise, can be an add-on to core. Thank you, Ruben, for that question. Let me see what's next here. So for organizations that deliver housing navigation or transitional support services that maybe have never billed Medicaid before, where does someone like them start with something like this?
Well, I think I can start, and Goldie, feel free to jump in, or Elaine. But I'll just say that I think kind of getting to know the payers in your community and others that are doing this work and looking for those partnerships is a great, very initial step, just to be aware of like who would be funding you to do this work, what do those contracts look like, what are the eligible services. And I think Goldie touched on a lot of the support that Health Roads offers, and kind of helping navigate that payer landscape of what the services and requirements are, and how that can best match up to what your organization is already providing. Go ahead, Elaine.
Yeah, and I can jump in. I think also finding what, for example, in California, Department of Healthcare Services has these different work groups that allow you to learn about some of these processes as well. And so getting involved there and utilizing upfront, like some of the services that they provide. So the TA Marketplace does pay for a lot of the technical assistance upfront for organizations like ourselves, community-based organizations who may not have that funding to do this infrastructure work. And so trying to navigate some of those processes to lean on partnerships like Health Roads that do have the expertise around this to help guide that process, especially the technicality with it, whether it's like, again, the verbiage or even just like the processes that they know will allow us to get to where we need with the contracted services with managed care plans or health plans.
I think the only thing that I was going to add to what Suzanne and Elaine already shared is that if you're looking to get reimbursed from a health plan, step one is to make sure that the health plan is open to have new organizations contracted. Some are full. They've already got CBOs, doing what they're willing to reimburse for. But many are not full. And there are some requirements in most of the states that all managed care plans and managed care organizations, CCOs, MCOs, MCPs, they all have to cover. So if they're not currently covering those in all of the areas that they serve, then those would be areas that would be an opportunity for a CBO.
Yeah, there was, questions. We've talked a lot about California, but what if we're in other states? How can Health Roads and Suzanne, how can you help with other states to figure out how to get this started?
I think some of those same steps mentioned, but really finding out where, what's being funded and where the opportunities are and where the gaps are. And I think when those opportunities do come up through Medicaid funding, those payers are often looking for the kind of ready to contract networks, right? People that are ready to hit the ground running. And so for me, I always go back to partnerships and like who is in that network, who is ready to go. And so making sure that there's just open communication and collaboration with potential payers and other service providers in the area, so that, when the time comes, you can really make the value proposition.
A little bit back to technology. So if an organization was interested in setting up QConnect, Goldie, what does their IT team need to do to be involved with that? What kind of technical capacity do they need?
Well, that is going to depend on what they need to be connected to and what the requirements are. So the first thing that we will do is have a discovery call. So really, at no cost, it doesn't hurt to just reach out to Health Roads, ask for that discovery conversation, and then we can start to find out what are you trying to connect to, what is your objective, what end result are you trying to achieve. And then we can start digging into what are the technology requirements. Do you have those resources on your team, or is that something that you need our help with to either do for you or to find additional resources? So those are all very common things that we deal with when someone reaches out to us with questions like this.
All right. Elaine, if you were starting all over today on this process, what's one thing you wish you knew beforehand that could help others getting started?
One thing that I wish I knew, to, well, one, I think just like being open to the process, because it is so complicated, there is a lot of things that may deter you, but understanding that there is a through line through it all, that once you like learn the processes, you lean on your partnerships and collaboration, that there is a way to get to that end side, and really being transparent, and really building upon partnership is a really important piece. I think the one thing that I wish that I really understood, is that it is possible, to get to there. And that there are different hoops that you'll be navigating towards, but at the end of it, it is something that our community is able to reach and something that we've already been doing, and that the state has made that possible in order for us to get to that end goal.
Yeah. All right. I'm gonna wait here to see if there's any more questions that roll in. In the meantime, I think we've had a great conversation today. I want to thank you, Elaine, Goldie, Suzanne, for bringing your depth of knowledge and experience, real world experience to this conversation. If your questions didn't get answered directly, you can feel free to reach out to Health Roads or reach out to your Bonterra account manager, your customer service manager. We'll make sure that we can get those answers to you. There's one thing I want you to take away is that this is all possible, right? There's the money's there, your clients are eligible. We just need to get this infrastructure set up. It exists. And like Elaine says, it's not the easiest thing between all the parties and contracting with the payers and all that, but it's doable. And Health Roads is here to help support, and Bonterra will be by your side as well. So we're excited to see more of you reach out to get going on billing. So, all right, Ashley, I'm not saying anything else, so we'll turn it back over.
Yeah, awesome. Well, Jill, you beautifully wrapped this up, but just want to reiterate, Jill, Goldie, Lane, Suzanne, thank you so much for taking the time to come and speak to the audience today, and kind of share your journey and share your knowledge and expertise. We really appreciate it. And I want to thank you guys on the line as well. Thank you for spending 45, 50 minutes with us. We hope that this session was valuable and that, like Jill mentioned, even though the process may seem daunting, that there is support there within Bonterra, within Health Roads. And there is a light at the end of that journey and a tunnel. And we're happy to support you on that journey. So just as a reminder, we did record today's webinar, and we will be sending that out to the email that you used to register. So you'll see that in the coming days here. But until then, again, just thank you so much for joining us this afternoon. And we definitely hope to see you at our next session. Bye, everyone.
Thank you. Bye-bye.